Next speaker, actually, Dr. Manisha Agarwal was, we missed him. So next talk is Dr. Manisha Agarwal. What is in a name? Newer nomenclature and criteria in uveitis. Dr. Manisha, please. Manisha is from Shrop's Charity Hospital, New Delhi.
A very good morning to all of you, and I apologize for missing from the hall when my name was called. So the talk for the day is what is in a name, newer nomenclature and criteria in uveitis. So let's first understand what exactly do we mean by a nomenclature. So nomenclature is basically a system of names or terms or the rules for forming these terms in a particular field of art or science. And apparently, we all know that there are more than 30 uveitic diseases classified based on anatomical involvement, and they have been basically broadly classified into anterior, intermediate, posterior, and panuveitis, or as infectious, autoimmune, eye-limited, and immune-mediated. Now, several clinical diagnostic criteria based on the sensitivity for uveitis is already there, but there is absolutely no well-defined classification criteria based on specificity, and the goal being to define a homogeneous group of patients of uveitis for inclusion in research studies and thereby minimizing the misclassification. So basically, the aim is that we all talk on similar terms, and thus the invention of the new classification criteria by Sun Working Group. So this is basically the second Sun standardization of the uveitis nomenclature for disease classification criteria. And it was basically a project which proceeded in 4 phases involving informatics, case collection, case selection, and machine learning. And this classification criteria has been primarily developed for 25 uveitic entities. For some of the diseases, the new Sun criteria is quite similar to the criteria which has been previously proposed, but update has been done with newer information, including virological criteria, immunogenetic criteria, and imaging criteria. The new classification criteria developed by the Sun Working Group seems to perform sufficiently well for use in clinical and translational research. Now, we do have these 25 entities which have been classified by the Sun 2 classification, and you have them broadly classified still into anterior, intermediate, posterior, and panuveitis. Now, I will just briefly touch upon the major important uveitic entities which have a little difference to the previous classification, such as the CMV anterior uveitis, and there are certain clinical clues that we are all aware of. We can have Poschner-Skoltzman-like phenotype with or without CMV. We can have Fuchs versus Fuchs-like CMV anterior uveitis with more endothelitis or endothelial cell loss, nodular endothelial lesions, often coin-shaped, with a surrounding halo and a patchy iris atrophy and rarely heterochromia. CMV anterior uveitis versus HZV or HSV uveitis, where CMV has milder inflammation and low endothelial counts, but nothing is a diagnostic phenotype of a CMV anterior uveitis. Now, why is it important for us to diagnose CMV? Because we know that acyclovir may work on the other 2 viruses but not on CMV. And if we diagnose CMV, then we know that the drug of choice would be ganciclovir, which will help us not only in the control of inflammation, but also is going to control the intraocular pressure and also will help in avoiding an endothelial cell count loss. So the key criteria which has been proposed by Sun is that it has to be a unilateral anterior uveitis with a positive aqueous humor PCR for CME, and we need to understand that no typical clinical features can be reliably diagnosed as CMV anterior uveitis. We can also be having immunocompetent individuals, unlike a CMV retinitis, presenting with CMV anterior uveitis, and this is the detailed criteria which has been proposed. Coming to Fuchs uveitic syndrome, again, if we have to differentiate, it will neither have endothelitis nor nodular or coin-shaped endothelial lesions, and this is an important feature to differentiate between the 2 entities. Coming to VKH, now it has been defined into 2 criteria as early stage VKH, which includes an exudative RD with characteristic appearance on FFA or OCT, a panuveitis with more than 2 of the 5 neurological symptoms and signs, and we can also have a late stage VKH including a history of early VKH and either sunset glow fundus or 2 of the uveitis signs and more than 1 of the 3 cutaneous signs. So this is how it has been defined, and what is important is that how do we differentiate it from sympathetic ophthalmia. So of course there will be no history of penetrating ocular trauma or a vitreoretinal surgery prior to the onset of a VKH. And these are the detailed criteria which have been defined to differentiate between early stage and late stage VKH. And as I mentioned, if we have to differentiate, because both of them are bilateral granulomatous uveitic entities, the most important would be the history of any kind of a trauma to the eye, where we are going to be diagnosing it as sympathetic ophthalmia and not VKH. As far as the Behçet's disease is concerned, again, we have a lot of criteria which has been defined, and there is also an understanding that oral ulcers are very important for diagnosing Behçet's disease using the IUSG criteria, plus any of the two following features such as genital ulcers, uveitis, typically defined skin lesion, and a positive pathergy test. The differences in Sun2 classification, when we were to understand, is that the hypopyon uveitis, which was given a lot of importance to diagnose Behçet's disease, was not really considered relevant now, as it was found in other entities such as HLA-B27 and endophthalmitis. And Behçet's disease was said to be primarily a clinical diagnosis and not dependent on the positivity of HLA-B51, as this has a high prevalence in general population where Behçet's is endemic. Its poor positive predictive value thus was not included in the new criteria. Coming to syphilitic uveitis can present as any anatomic class of uveitis, and thus it is a differential for any uveitis presenting in your clinic. So we cannot really say that any particular ocular finding can be classified as syphilitic. Anterior and intermediate uveitis, a serological testing is very essential for diagnosing it as syphilitic uveitis. It can also present as posterior uveitis and panuveitis, and imaging shows the involvement of retina, RP, or retinal vessels. So in a nutshell, anything and everything can be a syphilitic uveitis, and therefore it's extremely important that we do a treponemal test to really say it with definition or with definitive diagnosis that we are dealing with syphilitic uveitis. Intermediate uveitis again has been defined into two, as non-pars planitis type, also known as undifferentiated intermediate uveitis. And the key criteria for intermediate uveitis non-pars planitis type is a unilateral or a bilateral intermediate uveitis with having no snowballs in the vitreous humor, no snow banking on the pars plana. And other key exclusions includes multiple sclerosis, sarcoidosis, and syphilis. So this is the detailed classification, and I'm sure you can refer to the reference which I've outlined. Coming to toxoplasmic retinitis, again, it is a focal or a paucifocal necrotizing retinitis, and either positive PCR assay we get for toxoplasma from an intraocular specimen, or we have the characteristic clinical picture of a round or an oval retinitis lesion proximal to a hyperpigmented or an atrophic chorioretinal scar. Pars planitis, again, as I defined already. And coming to tubercular uveitis, again, a lot of criteria has been defined. Now, the primary difference between tubercular uveitis and between sarcoid uveitis, I think Anirudh has beautifully differentiated between the two entities, which are very often confused in our patients. So therefore, I would just conclude that this new Sun2 classification is basically an old wine in a new bottle. The classification criteria is primarily based on specificity, and this is basically with the aim to have minimal misclassification rate of uveitis, especially when we are doing research studies. Thank you so much for your patient listening.
I have read all the Sun2 classification 21 papers came. I don't use in practically in a case of VKH, where is the bullous retinal detachment, subretinal septin, OCT, do a serological test for syphilis to rule out. So I don't know what others feel like, there are some certain cases which is so clinically evident, and theoretically you should not do that. That syphilis is a mimic, and mimic any kind of uveitis, I agree. But where the diagnosis is quite obvious,
I agree. I think Sun has very categorically time and again said this is not a diagnostic criteria. These are the classification criteria. Like if you want to report, you want to classify, you can base it on Sun 2, because Dr. Biswas and myself, we were a part of Sun 2. It is never meant to be a diagnostic criteria and it should not be applied to diagnose a patient.
Uh, do this Sun 2 criteria included white dot syndrome, because this is a very difficult to diagnose those cases?
They have given white dot syndrome based on the data of the patients. The problem which occurred in Sun 2 was the images were very, very variable. So when they applied the data to machine learning, they could not analyze the images. So whatever the criteria has come up, it is what experts felt. So for white dots, IOSG is going to announce within next 2 weeks. We are taking up as something Sun 3, which is image-based diagnostic criteria for 5 of the white dots that we have started. So the initial brainstorming has been done. Very soon we will roll it out to the members.
So I would agree, ma'am, that basically what the Sun 2 is that when we are doing any kind of research studies, we all use the same terminology and classify the patients.
But you don't use this to make the diagnosis.
Right, I agree.
The clinic, it's not really required.